Is pain objective or subjective? It is very highly subjective. Is everybody's pain experience the same?
No.
Is everyone's expression of pain the same?
No.
Is everyone's experience with pain the same?
No.
Since it's highly unique, individualized, so therefore each person's pain experience is different. Okay, you can't say, oh, I saw that before, that patient is in pain. Okay, yes, that may be true. Some patients share the same characteristics, especially those with dementia and unconscious patients. So we will have to use the appropriate pain assessment tool when we assess and evaluate pain in our patients, because not all patients are alert and oriented. Some of them are confused. They have dementia. Some are not even conscious. They are sedated. So is every sedated unconscious patient pain-free? No. So we need to look at behaviors. Okay. So this is what I meant by we'll use an appropriate pain assessment tool for the appropriate patient. Can we use the numeric pain scale for everybody?
No.
How can a dementia patient tell you the number? Or an unconscious patient, sedated, intubated on a mechanical ventilator? How can they, or patients in coma, how can they tell you a number? Correct? So you should use the appropriate pain assessment tool. In every, and I mean every unconscious patient, pain must be assumed because these patients can't tell us anything. So therefore, we assume that they are in pain. So makes the pain assessment a routine part of your assessment, as often or if not more frequent than checking vital signs. So based on this idea, this concept, we use Margot McCaffrey's, this McCaffrey here, Margot McCaffrey, her definition of pain is what nursing uses. So this is our universal definition of pain. In nursing, pain is whatever the person experiencing it says, and it exists whenever they say it does. This part is not really testable, but this will help us determine the extent of the pain experience. Why is management of pain important? Because it affects the whole body as a whole. You look at here, so it doesn't just affect the physical body, but the psychological, emotional, and psychosocial. Because if you're in pain, are you social? Are you interactive?
No.
Are you productive at work? Are you the happiest camper? No, you're angry, right? You're unpleasant. You don't want to talk. You don't want to interact with people. So, right. So it affects you as a whole person and those around you. So it depends also on the role of that person. So let's say that person in pain is your manager. How do you think your floor will run? Your manager's in pain. She's miserable. He or she is miserable. You think he or she wants everyone else around them to be happy? No. Tendency is I'm miserable. Why are you happy? I can't be the only one miserable here. So tendency is they'll make everybody else's life miserable. Okay. So same thing. The patient will be the same. Patient's in pain, and here's the nurse, doesn't care. He hears the nurses laughing, smiling at the nurse's station, passing by their doorway, like this. How how does that nurse deserve to be happy and comfortable? I'm miserable and in pain here, correct? That's just human nature, right? So let's look at, in order to assess and manage it, let's look at the different types of pain, because can we use this same intervention for all pain types?
No.
Your intervention must be appropriate, and it all begins with the assessment. So you assess what type of pain are you having so that you can decide. And then, of course, we cannot prescribe medications, but you can ask the doctor for the appropriate pain intervention. You follow so far? Okay. So we have acute and chronic. Besides that, acute and chronic, aside from the description, they will have different descriptions. There will also vary in the duration. pain can also be called breakthrough. What is breakthrough pain? Now, this exists in chronic pain. Cancer patients have both acute and chronic pain, but in between these acute and chronic pain episodes, they will have something called breakthrough pain. By the word itself, breakthrough, what do you mean by breakthrough?
In between.
Okay, something that exists in between the acute and chronic episodes. Because this is different. Does this respond to the usual chronic pain experienced by cancer or other chronic pain patients? Is this the same type of pain?
No.
So therefore, does it respond to their usual pain medications?
No.
No. This breakthrough pain has an acute nature. So therefore, if your patient, say with cancer, is taking long-acting or extended release morphine, for instance, which lasts for about 12 hours, or oxycodone, OxyContin, for instance, we have extended release OxyContin, which is used for chronic pain, so it lasts about 12 hours. Can you use the same drug for breakthrough pain?
No.
A patient already is taking it and then they complain of pain. I have something pain. Oh, you're already on oxy. You're getting too much drugs. Is that the correct response?
No.
No, this is a different type of pain. Now it's challenging for nurses, especially if you don't understand the nature of pain, to accept this reality that what is pain again? Is it objective or subjective? So is there evidence of pain? Can you go to court and then prove that there is pain? No. The patient's self-report is the only evidence you need. Patient tells you they're in pain, that's true, unless you have other ways to disprove it. Is there any way to disprove it?
No.
No, we'll have to take the patient's word for it. Again, that's hard to accept for most people. Let's say this patient is like this. Look at me. Hey, nurse, can you, Alicia, can you give me some pain medication, please? And then I'm on my phone. Hey, what's up? Hey, everything good? Yeah. And hey, nurse, Felicia, where's my pain medication? Hey, yo, man, not nothing. I'm just chilling here. Okay.
How do you do that instance? Because I've seen it happen. That's very. Or.
What did the patient tell you? They're in pain.
I got a question.
You gotta think that one.
Say again.
The freaking flyers you put fake.
The frequent flyers? Okay, again, here's the argument. Can you prove that they're not in pain? Does each person have the same pain expression?
No.
Do I have to be like this to be in pain? No. Or right now, I have a headache. Do you know that I have a headache?
No.
No, it's highly subjective. So this is what I mean by, can you prove it? If your answer is no, then you take their word for it. Are we clear? Again, it's hard, right?
Yeah.
Mr. Kurt here is just giving a very good example. People who come to the ER, come to the hospital every month or every 2 months and get their fix and then they go home, correct? Okay, again, what did we just learn about Margot McCaffrey's definition? Totally subjective. There are further classifications. So aside from period, acute, chronic, and breakthrough, we also have the pathology. Pathology meaning what is the nature of the pain? What is causing the pain? Cause can be nociceptive in origin, meaning physiologic. It can also be nociceptive. We put noxious and somatic pain there, but there is also neuropathic type of pain. This pain is caused by abnormal processing of sensory input. Examples of nociceptive pain are any acute pain, surgical pain, visceral pain, visceral meaning organ. Let's say your liver hurts or your kidneys hurt. That's visceral. That's all. Nociceptive meaning it's caused by noxious somatic chemical substances, neuroreceptors for pain. That's what's causing the pain. Substances like substance P, neurotransmitters like what is inhibits prostaglandin. Okay, so those are the causes of nociceptive pain. Neuropathic pain is abnormal processing of sensory input. Examples are diabetic neuropathy pain, foot pain from diabetes, pain from, you heard of phantom limb pain, correct?
Yes.
Take phantom limb pain, for instance. How is that possible? How is the pain possible on the left leg when there is no left leg? Does that make sense?
Yeah.
So that is what we call neuropathic, which is what is the nature of the pain? Abnormal processing of sensory input. Okay, so it's nerve type of pain. It's not attributed to any physical toxin, any neuropain transmitter, nothing like that. So therefore, are these two types of pain treated the same way? No. Let's say opioids. Do opioids have any effect on neuropathic type of pain? It can't, because this is a different type of pain processing. So this is normal pain processing. This one is not. So therefore, these will respond to anti-seizure medications, antidepressant medication. Do you understand? Okay, so we have, this is what I mean by you assess the type of pain. What type of pain does the patient have? And then once you figure that out, then report to the doctor, and then the doctor will prescribe the appropriate treatment for that type of pain. Any question? All right. So here are the harmful effects. I'm not really testing it. This is nice to know. This is what I meant by pain doesn't just affect one part or one aspect of a person. It affects the entire body. So it just affects other body systems, endocrine, metabolic, cardiovascular, respiratory, all the way to quality of life. Because when you're in pain, do you sleep well?
No.
Are your relationships going well? Do you have a good sex life if you're in pain?
No.
All right, so it affects everything. Here are examples of each category of pain. So nociceptive are, I already mentioned, somatic, and any visceral pain. Somatic meaning, muscle, skin pain, so physical pain or more superficial. Whereas visceral, of course, refers to your organs. So treatment, look at the treatment for each. So column 2 is nociceptive, column 3 is your neuropathic, column 4 is mixture of both nociceptive and neuropathic. So nociceptive responds to your traditional opioid, non-opioids. No, so non-opioids are your NSAIDs, Tylenol, and any opioids. Those are your treatment for what type of pain? Nociceptive. What about for your neuropathic? I mentioned antidepressants, right? Anti-seizure or anticonvulsants. You can also use local anesthetics, but the first two are used, okay, for neuropathic type of pain. And of course, if it's mixed, then we use a combination of anti-seizure antidepressants or some non-opioids as well. These terms, transduction, transmission, and perception of pain, these are the processes involved before someone experiences pain, meaning, long story short, transduction is the process by which noxious stimuli you know, the source of the pain, you know, the tissue injury, the incision, the trauma to the tissue, produces chemicals, substances, and then the next step is these are transmitted. Next step is transmission. So that is transmitted by the neurotransmitters of pain, namely prostaglandin, dopamine, substance P. So this is now the transmission part. And of course, this is transmitted how? How does your brain perceive the pain, which is the last step, which is the perception? How is it transmitted to the brain? Through the spinal cord. Okay, and then gets to the brain, and then the brain interprets it. Ouch. Okay, that's painful. And then the next step is, of course, the patient's response to the pain. You can interrupt, since these are the, and then modulation is your response, the patient's response to the pain. Either they withdraw from the stimulus if it's that type, or you guard it, for instance, okay, if it's painful, or you jerk, for instance, okay, so that's modulation. So this is the the differences in how a patient responds to the pain. Now, the theory is you can interrupt pain by affecting any one of those steps in the transmission, in the pain process, meaning you can stop it, you can stop transduction, so therefore no transduction. Will there be transmission, perception, and modulation? No, because you interrupted it. If I can't stop the transduction, for instance, the patient had an incision. Can you stop that? No. Patient sustained the injury. So can I stop the transmission though? Can I stop it? How? What will I do? Because the transmission is through the spinal cord. What can I give the patient to stop the transmission? Nerve blocks, okay? Epidurals. Who has had epidurals here? Who gave birth through, okay, you had epidural. So therefore, did you have any pain? No, because they stopped the transmission. Okay? So they put an anesthetic in your spine and then stop the transmission of pain. You can also alter the perception. You don't stop the transduction or the transmission, it's going. However, you're changing the brain's perception. You're giving them opioids. So who has ever had opioids here? And did you feel high with the opioids? Okay.
Yes.
So what did the medication do? Did it stop the transduction and transmission? No. Transduction and transmission continued. However, did your brain perceive pain? No. We gave you opioids to alter your brain's perception. Okay. Instead of feeling pain, the brain did what?
That's how it works.
All right.
You know, we have that in mind.
Okay, so that's perception, and then etc. So you understand why we have different modes of pain. Okay, all right. So we're trying to interrupt the pain process. So either you change the perception, which is what our opioids are designed to do, or you can do you can block transmission, spinal blocks, okay, etc. Now let's go to assessment. This is the first part. So your pain management will be ineffective or inappropriate altogether unless your assessment is thorough, comprehensive, and appropriate. So we use different methods. So here are, to what Kurt's comment earlier. So this will help you accept the reality of pain. Acknowledge that everyone is entitled to their opinion. Does your opinion count in pain? Are you the one experiencing pain?
No.
So does your opinion count?
No.
No.
That's what I'm like.
You're not in pain. I'm in pain. So only my opinion counts as far as assessment. You understand? Okay, so the sooner you accept that, then the sooner your pain management will be effective. Clarify that the sensation of pain is subjective and what does it say? Cannot be proved or disproved. Imagine if you are the patient laying in that bed and then your nurse ask you for evidence. Like, you don't look like you're in pain. You're on your phone. I just saw you. You were FaceTiming your bros. You can't be in pain. Stop this nonsense. Can you do that?
No.
No, this statement clearly says it's subjective. You cannot prove or disprove the presence of pain. Next, quote recommendations from clinical guidelines and again by the American Pain Society. This is what's advocated by the American Pain Society. Now, it's up to the doctor if they don't believe or they highly suspect the patient is faking it. We do have a few challenges, and we'll discuss those 3 challenges later to pain management, and it will also help you accept the reality. Thank you for reading. Kurt.
Although accepting responding to the report of pain will result in administering an analgesic agents to an occasional patient who does not have pain, it also helps to ensure that everyone who does have pain receives appropriate care. Healthcare professionals do not have patient field assessment and treatment simply because they believe the patient is not being treated. Pain is a personal experience manifested uniquely by each person. It is important to carefully assess and reassess pain when administering analgesic medications.
All right, I hope you take this to heart and understand that this is a fact. Okay, so this is from your textbook. This is not somebody's opinion. All right. Now, the last statement, it says here, carefully assess and reassess. In EPIC and in most EHRs, whenever you assess pain and you document it on the vital sign sheet or in the course of in the MAR, you gave a pain medication, for instance, whether that's Tylenol or any opioid or an NSAID, for instance, that system tracks it. And exactly 30 minutes to an hour, it will ask you, it will appear on your work list asking you to reassess the pain. It helps you actually with documentation because do we always remember to reassess? No, your shift can be very busy this way. Are you able to forget? No, because it shows up on your work list. Unless you document it, unless you complete it, it will not disappear. So therefore, you can't finish your shift unless you reassess. All right. So it's part of the assistance, a digital assistance to us nurses. Okay, so what do we assess? So we do a complete assessment. Now, it doesn't matter what type of pain it is, whether it's cardiac pain, wherein the patient is having a heart attack, for instance, pain is pain. So you always ask all of these questions whenever a patient tells you that they have pain. Doesn't matter again, whether it's nociceptive or neuropathic pain. What do? Complete. Because most people, and I noticed that during our simulation, when someone has pain, what do? When someone has pain, you go straight to the MAR, right? You don't complete the assessment. So when you do your charting, do you even know where the pain is?
No.
And then you call the doctor. Let's say there's no order. Then you go call the doctor. Hey, your patient has pain. Where is the pain? Okay, hold on. Let me ask. Where is your pain? It's in his head. How bad is it? How bad is your pain? What does that make you look like? An idiot. Okay, let's face it. You're an idiot. Okay, that's what you look like in front of the doctor. So first, you look for the location. Okay, where is your pain? How bad is it? Okay, let's pause here with the intensity because intensity has different types. Okay, so we have different tools in intensity. The most commonly used is, of course, the numeric pain rating scale. So we ask them, okay, 0 to 10, 0, no pain, 10 being the worst. How bad is it? Pain. Patient tells you 20. Do we put 20? No, there's no such thing. The 10 is the maximum. So here are a few examples on how to perform the pain rating scale. I won't read that for you. So here are the different tools to assess intensity. You know, numeric pain rating scale. Next is the Wong-Baker faces. So the what does this look like?
Smiley faces.
Okay, smiley faces, right? Smiley to frowny faces, right? So, or none like this, and it corresponds, there's a number attached to it, correct? So therefore, even if you're doing the patient points to a smile, you can still attach a number to it. Okay, so Wong-Baker faces is a combination of images and numbers. Okay. Who do you numeric pain rating scale? This can be given to 7-year-olds and up. Below 7, I'm not saying 6-year-olds are, incapable of using the numeric pain rating scale, but the creator of Wong-Baker faces, the clinical people, they recommend that they use this under 7 years old. Okay. So this can be used, you can even use it for adults. So 3 years old actually can use, sorry, it's 3, it's not 7. So you can use this for 3-year-olds and up.
What if you can't speak? Point at it.
What do you mean that the patient can't speak?
Yeah, non-verbal patient.
It's okay, they can point to the scale. Yeah. So as long as you use the correct language though.
Oh, somebody may have facial expression.
Hmm?
I said some patient you can see the intent by facial expression.
Yeah, you can also look at the facial expression, or you can just ask the patient. As long as the patient has cognition, meaning they're not cognitively impaired, there's no autism or developmental delay, they can use it. Faces pain scale. So this is a revised type of Wong-Baker faces. Personally, I don't really see a difference between faces and Wong-Baker faces. It's looks the same to me. Then we have the verbal description. Patient will simplify only. You can use no pain, mild pain, moderate pain. There, it's simple. Okay, they use words, so that's verbal descriptor. So who do you think can use this? Why can't they use the visual? Because they can't see. Okay, patients with visual impairment, can you use the Wong-Baker faces? No, but they can hear. So can you use the numeric rating scale? Yes, but if you want, you can also use this one. Then the visual analog, definitely patient can see. Now, something not mentioned here on the list, but I think it's somewhere down, is this one. So we have PAINAD and FLAC. Let's start with FLAC. That stands for facial expression, leg movement, activity, crying, and consolability. This is for infants and younger than 3 years old. FLAC. So we're using the patient's behavior instead. Now, this is only for young children and infants. Can we use this in the dementia patients? Not appropriate. Okay. But however, when we go to the tool we use for dementia patients, which is PAINAD, it's actually the same, FLAC. But of course, do we use FLAC? No, because that's not appropriate. So we will use instead PAINAD. But if you look at the PAINAD, let me show you because it's not written in the textbook. So there are about 6 criteria for PAINAD. No, sorry, 5. First is breathing, negative vocalization, facial expression, body language, and consolability. So this is PayNet. All right, and it corresponds, the highest number is a 2, and then of course it will have you total your score, and that will be your pain. It's not perfect, but it's more or less closest we can get to. Okay, so you use this to dementia patients or anyone with cognitive disabilities. You understand? Okay. Then there's CPOT. This is for our sedated patients in the ICU. So we use CPOT.